Over the past couple of decades, we have learned quite a bit about recurrences in Crohn's disease after surgery. We've learned how recurrences occur, where they occur, how similar they are to the original disease. We've also learned that there are many predisposing factors to Crohn's disease. Probably the most important is smoking. If a patient with Crohn's disease is a smoker, he or she is at a very much higher risk of recurrence after surgery. But there are also other factors which are important, such as the extent of the original disease, the genetic factors, how frequently patients have required surgery in the past, and many other things that are important in the computation of the risk that the patient has to develop additional recurrences of Crohn's after surgery. Now, for many years, we thought as surgeons that we could not do anything at surgery to mitigate, to lessen the risk of a recurrence after surgery. Well, that is not true. There are a few things that a surgeon with expertise in inflammatory bowel disease and specifically Crohn's disease can do at surgery to make sure that that very patient has less of a risk of a recurrence down the line. It was in 1976 that a surgeon from England, Emmanuel Lee, described two bowel-sparing procedures, strictoplasties, in Crohn's disease. One was the Haneke-Mikulik strictoplasty, and the other was the Finney strictoplasty. These strictoplasties are still used nowadays in the majority of patients. They are very good techniques in the armamentarium of a surgeon dealing with patients with Crohn's disease. These strictoplasties are good for limited segments of Crohn's disease. They are not particularly good for extended segments of Crohn's disease. And so it was in 1993 that I came up with a new strictoplasty. It was named the side-to-side isoperistaltic strictoplasty, devised to really address extensive segments of Crohn's disease. Nowadays, it's also referred as to the Michelassi strictoplasty. And now all strictoplasties, whether it's the Haneke-Mikulik, the Finney, the Michelassi, you name it, have in common a very important principle, which is to save bowel rather than removing bowel. And what we have learned over the past 20 years, 25 years, is that the bowel possibly returns to the initial function of normal bowel over time. And the other important things that we have learned recently is that strictoplasties have a preventive effect toward recurrences. There are some situations where strictoplasties, bowel-sparing procedures, cannot be performed in patients, and in those situations, the Crohn's disease needs to be resected. The intestine affected by Crohn's disease needs to be resected. Once it is removed, obviously the two ends of the intestine need to be put together. We call that an anastomosis. And there is hope now that new kinds of anastomosis may actually prevent recurrences. I think we are in a much better place nowadays than, say, 20, 30 years ago. I think that the medical treatment of Crohn's disease has vastly changed with medications now which really are changing the natural history of Crohn's. We really have made a lot of progress in the surgical treatment of Crohn's disease. First of all, the strictoplasties, the bowel-sparing procedures are now accepted. We know how to do them. We know when to employ them. And they have the great advantage of saving bowel, not resecting it. And as I mentioned before, they have the great advantage of protecting against recurrences. The other thing is that new anastomotic techniques, new ways to put the intestine together, may prove to be better than the ones that we have known for a long time in terms of preventing recurrences. The treatment of patients with Crohn's disease is much better if given in a center that brings together the expertise of many different specialties: gastroenterologists, surgeons, radiologists, pathologists, nurses, and so forth. The ability of the surgeons and the gastroenterologists to work together is essential. After surgery, the surgeon is key in helping the gastroenterologist in figuring out what kind of preventive medical treatments the patient should undergo to lessen the risk of recurrences, lessen the recurrence of symptoms, and potentially the need for additional surgeries down the line.